This week on the BackTable podcast.
When erectile dysfunction occurs in a man under 55 years of age, I think it's really important for us to consider, doing a calcium score, consider getting a preventive cardiology consultation, because that may be someone who in the next 5 to 10 years is seeing us in the ER with a heart attack. Like I said earlier, patients present typically 2 to 3 years before their cardiovascular symptoms, they present with erectile symptoms. And so this would be my message for urologists. And I look forward to sharing patients with you guys and sharing information. And hopefully we get more data that sheds light on this issue and the intersection between cardiology and urology.
Hey folks, my name is Dr. Amy Pearlman. I'm a board-certified urologist with expertise in sexual, hormonal, and genitourinary health. And I have one of my most favorite people on our podcast today on BackTable Urology. I have the one and only Dr. Dapo Iluyomade. Dr. Dapo, say hello to the crew.
Hi, everyone. Thank you for having me, Amy. It's great to be here.
And I actually refer a ton of patients to Dr. Dapo. He is a preventative cardiologist. Do you say preventive or preventative cardiologist? What's the terminology?
Both are used, actually. I prefer preventive, but, you'll see preventative. Not sure which one's correct, actually.
Okay, perfect. Just wanted to make sure. I wasn't sure what the cool kid lingo was these days, Dr. Dapo. So for people listening, today's discussion is really going to be on the basics of cardiology and more so with a focus on how it impacts us as urologists or aspiring urologists. Dr. Dapo is a preventive cardiologist at Miami Cardiac and Vascular Institute with Baptist Hospital, and he focuses on optimizing cardiovascular risk and promoting long-term wellness. So the patients I routinely actually refer to Dr. Dapo, who sing his praises, are guys where I'm checking their advanced lipid panels, and their lipid panels are abnormal, whether their lipoprotein little a is elevated, their apolipoprotein, B is elevated, or guys who simply say, I'm interested in optimizing my health and wellness, and I would like to speak to someone to understand my cardiovascular risk. And so those are the guys and ladies that I actually send to Dr. Dapo. So Dr. Dapo has advanced training in lipidology. He even said earlier before this recording, that's what gets him fired up. So we might ask him some questions regarding lipidology today. And he's known for his patient-centered approach. I hear that all the time from my patients, and really integrates lifestyle, technology, and advanced diagnostics to help people lower their burden of heart disease. Dr. Dapo, thank you so much for joining us today on BackTable Urology.
Thank you so much for having me. And I refer a lot of patients to you as well. So that is a good lead into our conversation that we're having today.
Yeah, who would have thought? And I know a lot of people are talking about this collaboration between a cardiologist and a urologist, and it kind of sounds like the beginning of a joke. A cardiologist and a urologist walk into a bar,
Exactly.
And then what happens, right?
Exactly.
With heart disease being the number one risk factor for erectile dysfunction, it certainly, we're seeing all the same patients, just a different time and a different day. So let's begin with this. When men come to see you specifically for cardiovascular health, how often are they bringing up erectile dysfunction?
Yeah, so I think it comes up as often as one asks. I would say in a preventive cardiology clinic like mine, it probably surfaces far less than it exists. Population studies show that approximately 20% of men over age 40 have at least mild ED, and yet less than 20% of them bring it up. And so I usually ask every middle-aged male patient of mine a normalizing question. Are you having any issues with energy, mood, sexual performance? How are things in the bedroom? To kind of get them more comfortable with speaking about it in my office. And oftentimes I get the response, actually, yes, I do. And so that opens up or unlocks an important window on vascular health, and we can take it from there and discuss things further.
So I guess my follow-up question to that is, a lot of us as healthcare providers, we don't ask certain questions because we know that that's going to elicit potentially a 5, 10 plus minute conversation. And if it's not something we treat, we need to have an exit strategy. So if a guy says, oh yeah, I took Viagra in the past and it doesn't work, or yeah, I have some major issues with ED, as a cardiologist, where do you go from there?
Yeah, so what I really start with is getting them to understand the relationship between ED and cardiovascular health. And we don't all have 10 minutes for that discussion. I usually kind of give them an introduction. I mention that we know penile arteries are about a third the size of coronary arteries. And so a lot of times when endothelial dysfunction begins, one may experience ED roughly 2 to 3 years before symptomatic coronary artery disease. And I try to give them the bits and pieces, and I say, hey, what we're going to do is a preventive cardiology workup. But what works for your heart is also going to work for your erection. And then I give them a card to a urologist like yourself who, luckily nowadays, urologists and cardiologists are building these relationships through these patients to work on preventing their risk of cardiovascular events as well as improving their sexual performance. So yeah, it doesn't have to take, 15, 20 minutes to discuss it. I think we build a relationship over time, over multiple visits, and we can have more and more discussions if they have questions.
So it seems like in a similar fashion that a urologist would use the penis and erectile function as a motivator, you do that as well. When I meet with other referring providers and cardiologists like yourself, my message is pretty clear. It's my job is to reinforce your message. And so I try to reinforce the importance of good cardiovascular health because of its association with the reason that prompted them to see someone like me. And it seems to be a pretty good motivator. I love the pen analogy, and I just want to make sure, because you're a cardiologist, if this is an appropriate analogy, but I love showing people a pen, and I push it out and I say about the tip of that pen is about the size of a cavernosal artery, which I can vouch for. That is about the size of that artery. And the back part of the pen is about the size of a coronary artery. So of course you're going to see disease in this smaller artery before it shows up in this larger artery. What do you think about that, Dr. Dapo?
I actually like that. That is something that I might steal from you and use tomorrow in my office. I think that's
excellent.
That's exactly the kind of visualization, practical, relatable information that you give to a patient, and it really sticks with them. Every time they pick up a pen, they're going to look at it a little bit differently.
Yeah, absolutely. Now, I cannot take full credit or actually any credit for that analogy, but I'm glad I could share it with you.
Yeah. No, I've never heard that one.
I actually want to take a little bit of a step back here. What is a typical patient who shows up in your clinic? What are his questions or her questions? And when you say you do this preventive cardiology workup, what does that workup typically entail?
Yeah. So, the typical patient, when I see them, they're either someone who has a family history of cardiovascular disease and they're concerned about their own risk, or they're coming in with some type of symptom that they think may be related to their heart. Usually they're not bringing up erectile dysfunction unless I bring it up. But I guess my highest risk patients are those who already have known coronary artery disease or heart failure or cardiomyopathies, arrhythmias, et cetera, or those who have already had an event. So that's my highest risk group of patients. So they've already had the heart attack, they've already had the stroke, and they're coming to me to prevent that second event. And so depending on the patient, my approach is a little bit different. And the degree of urgency that we kind of go through the steps of my framework are a little bit different. So I go through essentially 4 steps. So the first step is to risk stratify the patient. What I want to know is, is this a low risk patient that I'm dealing with, or is this a very high risk patient that I'm dealing with? If they've had an event, I already know they're very high risk. But for those patients who maybe have not had an event, maybe they have a few risk factors, high cholesterol, lipoprotein A, you mentioned earlier, family history. I want to get a little more of a fine-tuned risk stratification. And there are a lot of ways for me to do that through blood work, sometimes advanced lipid panels, but definitely checking things like an apolipoprotein B, checking for chronic inflammation through a high sensitivity CRP, getting a sense of their waist circumference or BMI if I can't do that, sleep apnea screening. There's a lot that goes into that. And then I want to know what's happening inside the body. And so for those patients who are borderline or intermediate risk, I always do a CT calcium score. And what that is a quick 2 or 3 minute CAT scan of the heart. We look directly at the arteries and we give them a score that correlates with the amount of plaque that they have in their arteries. And that score really helps me remove that gap that exists between our risk scores and risk stratification and what's happening within the patient's body. We know that there are some people who have risk factors and don't develop disease, and there are some people who seemingly have no risk factors and develop disease, and there's still a gap in our knowledge with respect to that. Maybe it's environmental, maybe it's genetics, maybe it's a multitude of things. But the calcium score really helps me match my lab-based risk assessment with what's happening in the body. And then we move on to, interventions. So lifestyle is always first. This is where we start with exercise. We stress both aerobic and strength training, resistance exercises. We talk about diet. Mediterranean diet is my preferred style of diet, but really just encouraging them to eat a well-balanced diet, one that's rich in natural omega-3s, low in processed foods, eating more whole foods, etc. And we take that step by step. I encourage them to reduce their stress, which I'm sure you would agree that high levels of stress or anxiety can also affect sexual performance. And I make sure that they try to get quality sleep in addition to an adequate quantity of sleep. And then when we go into therapies, this is where you and I may have a discussion because some of our medications can affect sexual performance. And, that may be at a later visit if it's necessary. And we kind of go through that step by step. And it's a negotiation. It's a partnership rather than a mandate or a dictatorship. Me telling them, hey, you need to take this and this and this. It's really, what works for you, but also works for me.
Yeah, no, I love that. And that's exactly the way that my patients describe their visits with you is you're on the cutting edge, you're getting the appropriate workup, and they sit down and they feel like you're really getting this personalized approach. So for the urologist listening, if we kind of want to tee up our patient, if we're going to send them to, let's say, see a preventive cardiologist, there are certain labs that I know you want. So I'll get a comprehensive metabolic panel. So that includes electrolytes, includes glucose, lipid, hepatic panel. I get the HSCRP, I get the advanced lipid panel, and then I'll get like my typical labs, which is going to be like a hematocrit or a CBC. Typically get the full CBC if they're seeing you. See, I'll typically check a vitamin D, sometimes a B12, and testosterone and other hormones. Are there any labs that I'm missing there that you would find helpful in your evaluation?
Yeah, so I think every patient who walks through my office should have a lipoprotein A either on file or where I'm ordering it. And it does come in the advanced lipid panel, so you will get it as part of that. And I really appreciate it when I see that. One, because lipoprotein A is essentially an LDL cholesterol with an ApoA on it. And what that ApoA does is prevent it from being cleared from the body. So none of our medications, none of our lifestyle changes, et cetera, clear lipoprotein A. It's about 95% genetic. So you're born with a level, and it pretty much stays stable from age 5 to age 105. And it affects 1 in every 5 people globally. So we're talking about 1.4 billion people have elevated lipoprotein A. And when it's above 125, I know that the individual's lifetime risk of a heart attack or stroke is 2 to 3 times that of someone with a normal lipoprotein A. So this is the one lab that I would say usually I'm not getting when I get a referral from, your standard specialist or primary care physician, and it's something that I order in everyone. The other thing that can be helpful, especially in patients who have had an event or who have known disease, is a high sensitivity CRP. Now, depending on where you get your advanced lipid panel, it may come with that, or it may be if you order the advanced lipid and inflammation panel, then it'll come in that. And a high sensitivity CRP is really addressing something called residual risk. And so we know that despite all of our efforts, people who have disease and we're controlling their blood pressure, their weight, their diet, their cholesterol is normal, they're not smoking anymore, they've done everything that they can do, a significant number of those patients still go on to have events. And what we've identified is that if they have elevated levels of chronic inflammation or inflammatory markers, that this contributes to that event. Plaque formation every step of the way, all the way up until plaque rupture and a heart attack, is an inflammatory process. And so we can check that with HSCRP. Our goal is less than 2, and it's very easily checked in a speckled top tube that you would get with a comprehensive metabolic panel or lipid panel, et cetera. So those 2 tests, I think, are key for me to put the whole picture together.
Awesome. That's very helpful. So you're reinforcing what I'm already doing, which is great.
Yeah. No, I think it's awesome. And when I see your patients, I'm very pleased to have those labs available, because then we can move on to the next step. That helps us a lot in making that initial consultation as fruitful and beneficial for the patient.
Yeah, it makes complete sense. It's like the guy who shows up who's concerned he has testosterone deficiency but doesn't have any hormone labs.
Yeah.
So we're talking about it, but not really I can't offer him personalized care in that discussion. And it's definitely a less thoughtful discussion. So far during this podcast, we've really focused on men's health, male sexual dysfunction. Does the topic, and we know that cardiovascular disease is a leading cause of morbidity and mortality in women, does the sexual health conversation in women ever come up?
Yeah, so I would say the sexual health conversation in women does come up. It comes up less so. I found that in my practice, when I ask that question, it usually leads into a discussion about perimenopause and menopause. And what we know about menopause especially is that as women enter menopause, their cardiovascular risk begins to increase, ultimately until they catch up to men at about age 65. So prior to that, women have the benefit of estrogen that almost has a cardioprotective benefit. But when those estrogen levels start to drop, then they develop a more metabolic syndrome type pattern. When you're checking their labs, you may see their hemoglobin A1C starts to creep up. They start developing more central obesity. It becomes harder to lose weight. Their metabolism slows down. The triglycerides go up. The HDL starts to creep down. And so we see these changes. And alongside that, we also, in our discussions, will find that women have sexual dysfunctions as well. I think it's less talked about. I think we know less about it. And that's probably, to the fault of, the cardiovascular community, that we have not included women in a lot of these studies, and we need to do a better job of that. And I think that, the leadership across our journals and our professional societies now have really made it a point to address these issues in our research.
Yeah, it's interesting because this pen analogy is also relevant for women. In fact, the size of the clitoral artery is about the same size as the tip of the pen as well. I think the challenge is most of the clitoris is hidden. So when it's not working, you can't see it not working. You just may feel it not working. And so I think that's where it's a little bit more challenging, I would say, in explaining this to women versus men. But the anatomy is pretty much the same.
That is very, very good for me to know. And I will definitely keep that in mind the next time I meet with a female patient who we discuss this. Very helpful. Thank you.
I love it. Changing medicine, changing lives.
Yes, indeed. The physiologic principles are identical. So, it's something that we should discuss more. I'm definitely going to make it a point to explain it in the way that you just did, because that can be very helpful.
I love that. We even within the sexual medicine space, we're now really have only started talking about this as well in terms of cardiovascular health and female sexual dysfunction. And I know there's one company in particular that's going to be developing something that can actually look at clitoral blood flow. I think that's going to be fascinating once we can start tracking that.
Yeah.
And maybe its association with, cardiovascular health. So that's kind of on the horizon, something I'm looking forward to hearing more about. So actually, you had mentioned perimenopause and menopause. So I think that's a good segue in terms of talking about the guy who comes in, for example, and you mentioned you'll ask about fatigue and mood in addition to sexual health. How does testosterone or hormone therapy, what are people asking about it when they come to see you? Are they bringing it up? And are they bringing up concerns related to cardiovascular health that they think are associated with testosterone therapy?
Yeah. So this is actually a question that I get way more often than I thought I would. And it's come up quite a bit over the past year or two. I think as more men are getting treated, it finds its way into my office more and more. I had a gentleman just yesterday come into my office and ask me about that very question. Should he start testosterone therapy? His testosterone has been low or borderline for a number of years. He's tried everything, it hasn't worked. And he's afraid to start testosterone replacement therapy because he's concerned about cardiovascular risk. And what I told him was, I actually pulled up 2 studies. So what we've done in the cardiovascular space and in the prevention space is really look at what the current practices are from urologists. What are they currently doing with respect to TRT and what doses are used, and studying that population. And what we find is that a lot of the fears that we had many years ago are not as significant as we once thought. So we know that testosterone replacement therapy, when done by a licensed professional who knows what they're doing and is using conventional guideline directed dosing, when those patients receive therapy, their cardiovascular risk actually does not increase. We used to think that it increased risk of thrombosis, of even cardiovascular events, but you don't see that when you study them in a randomized controlled trial using conventional therapies. So I encourage my patients, if they've found that they have low T, and usually they're symptomatic and they're struggling with that, I tell them to go ahead and start the testosterone therapy. We're going to evaluate their cardiovascular risk. If anything changes with respect to their cardiometabolic profile, or if they have any issues, we can deal with it. But honestly, I do not expect them to have any problems. So I encourage it. I think that it's a big problem. It's a bigger problem that we probably know about, and men should get treated.
Yeah. I think it's rare that we sit down with another type of specialist and say, okay, let's put this topic on the table. What are you telling him? And what am I telling him? And is our message the shared message, right? And obviously there's a lot of misinformation out there. And sometimes all it takes is one very well-publicized paper that will change clinical management for decades. And it takes then a lot of papers to then reverse what may never have been the truth, or, may never have actually been the appropriate conclusion in that paper. And so it's interesting when you look at our AUA guidelines, it specifically states in the guidelines and is supported by research that low testosterone is a risk factor for heart disease.
Yes.
And it's been very beneficial that the Traverse trial was recently published, because now that gives us as urologists a little step, to stand on, to say, look, we've done the largest trial to date looking at men with known risk factors for heart disease, and there was no increased risk of a major cardiac event compared to placebo. So even with that recent trial, oh my goodness, the cardiology fields and urology fields are really melding.
Yeah, I think, this was phenomenal for them to, for the researchers to do that study. I think it supports, that cross-section of urology and cardiology. It really brought it to the forefront, brought it to light. The adoption, as you mentioned, in medicine takes time to change practice because there's a lot of inertia. People are used to doing the same things. They're used to, they learned this a number of years ago. And so, no one gets testosterone, no one gets estrogen because there's this increased risk. I think studies like Traverse, and with the public's actually adoption of those findings and going out there and sharing that data with people has really helped quell some of those fears. So yeah, absolutely. I have no problem with it in my practice.
I will just say, like with that study though, what I do say with a somewhat caveat is they use topical testosterone, and their definition of success was kind of like a low testosterone value. And so what I tell my patients is, can we say that the safety profile of the injectable testosterone or the oral testosterone that I'm going to put you on, can I say that that has the same safety profile of the topical therapy if I'm getting your levels higher? And the reality is all of these formulations have different pharmacokinetics.
Yes.
So we really can't say that this one trial says that every testosterone formulation is safe. With that being said, testosterone cypionate has been around for like 50 years. So if that caused, a statistically significant increase in major cardiac events, Dr. Dapo, we probably would have seen it by now. True or false?
Yeah, I totally agree with you. I think if there were a bunch of middle-aged men having heart attacks who are all on TRT, or you would have heard about it, it would probably be on the front page of the Cardiology magazine or American Heart Association's webpage. I think, this is where sometimes research lags clinical practice. And we see that a lot in the prevention space. We're moving a lot faster than the research is moving. You want to do it understanding the medicine. If you feel like you're doing the best thing for your patient, I think that's what we should be doing. And I think Traverse is just the first step in kind of confirming what we already knew. I'm excited to see what else comes out. We run into the same issues with estrogen replacement therapy in women with menopause. For many years, that was a big no-no in cardiology. And now people are coming around to it, understanding that leaving these folks untreated actually is not helping us in terms of reducing their cardiovascular risk. So it comes down to a risk-benefit evaluation for each patient. And, with shared patient decision-making and making sure that the patient is fully informed of the risks, I think it's perfectly fine to proceed the way that, we are and that you are.
I was having a recent conversation with one of my colleagues, Dr. Rachel Rubin, who's a fellow urologist, and she said we oftentimes think about the risks and benefits of starting a therapy. We don't talk about the risks and benefits of not treating someone, with someone who has, let's say, a hormone issue. So I want to ask like 2 follow-up questions related to hormones, and then I really want to delve into some of the common medications you prescribe as a cardiologist and what urologists should know about their risk or low risk for sexual dysfunction. So
Absolutely.
is there any type of like man or woman that, let's say, I saw them in clinic and I put them on, let's say, either like estrogen therapy or testosterone, and I sent them to you, where you would gasp and say, oh my goodness, I cannot believe Dr. Pearlman started this person on hormones. This person is not a good candidate. And I have my own person in mind, but is there anyone where you would gasp?
Yeah, I think the highest risk population group for me would be an individual who maybe has a genetic clotting disorder. They have a known genetic clotting disorder, and they've maybe had thrombotic events. I think that's a higher risk patient where we want to be a bit more careful. You mentioned topical testosterone versus injectable. And, these are the conversations that we would have with their other specialists, whether it be you or Michelle, discussing, hey, maybe we should use a patch, or we use a lower dose in this patient because of this and that. So I think those patients, and outside of that, even in the individuals who've had an atherosclerotic cardiovascular event, I watch them more closely, but it's not an absolute contraindication to using hormone replacement therapy. If we're doing our job as cardiologists, they should do fine. So, I say really it's those prothrombotic patients are going to be the ones where I say, okay, let's sit down and have a conversation and discuss if there are any alternatives.
Yeah. The one like male patient where I would be a little bit more conservative would be someone who has congestive heart failure, because when I put them on testosterone, I can increase their estrogen. That can make some men retain fluid. And so I don't want to make them have an acute on chronic exacerbation of their CHF. And I rarely see those patients, but those patients I'm going to be following more closely.
Yes, I would say for those patients, especially those with an ejection fraction below 40, is a situation where, we watch them a little more closely. For heart failure with preserved ejection fraction, I haven't seen it as much, but I can't say that I've had too many patients with those two conditions. But definitely with a low EF, we should proceed cautiously. In that patient population, we proceed cautiously with everything. So it makes
So
sense.
pretty par for the course there. I've had a recent change in my practice management after having some discussions with two of my colleagues, Dr. Larry Lipschultz and Dr. Alex Tatum, regarding testosterone and lipid panels. And they actually routinely check lipid panels because they've seen LDLs go up and HDLs go down. And when I asked recently Dr. Lipschultz at what levels would you be concerned about that, he didn't give me a number, but he said even at pretty low levels. So I was checking lipid panels on most of my patients because a lot of my patients don't necessarily have a primary care provider. But with my follow-up labs, I am now checking lipid panels more often. Like if they haven't had one in the last year, I'm definitely checking it. And if they had an abnormal value in the past, I'm going to check that a little bit more sooner on follow-up. What are your thoughts on lipid panels in this setting?
Yeah, I absolutely agree. I think that is one of the side effects, if you will, of hormone replacement therapy. And it's something that we see. I totally agree with checking a lipid panel. I think if they haven't had one in a year, absolutely. I check them as frequently as twice a year. And for some higher risk patients, even more. Definitely within a year, I would check a lipid panel. And with respect to the lipid panel, LDL cholesterol we know has a linear relationship to atherosclerotic cardiovascular events. But now with the advent of new imaging-based diagnostics, we know that not everyone develops disease at the same rate. So even in the highest tertile or quartile group of LDL cholesterols, if someone has a calcium score of 0, their 10-year risk of having an event is roughly 2%, which is below the threshold for us to initiate statin therapy. We typically initiate statin therapy if the 10-year risk is above 7.5%. This is a patient where a calcium score would really matter in terms of how we approach their care. And if we see the lipid profile change, I wouldn't necessarily stop therapy. I would just really optimize their care as best we can based on their risk. So are they a low risk patient or a very high risk patient? Obviously, someone who's had an event before, we do not want to see their HDL go down and their LDL go up. And so when we start to see those changes, either our therapy needs to change or we need to speak with their urologist to maybe change the dosing schedule of their hormone replacement therapy.
So I know how much you love talking about lipids. So I have one more question on lipid panels. I have a lot of my patients on oral testosterone, and when I check their follow-up labs, I have to check their labs typically 3 to 5 hours after their morning dose of testosterone, and they have to take their testosterone with food. But when I also want to check a lipid panel, that means I have to get them to get their labs at 2 different times, which is annoying for them.
Yeah.
How much does it matter for me to get a fasting lipid panel in these scenarios?
Yeah, so a fasting lipid panel is really most important for the triglycerides and therefore the LDL. So the LDL that you're going to get on a typical, routine lipid panel is a calculated LDL. You oftentimes see LDL-C calculated if you look at the result. And they calculate it based on an equation that involves the triglycerides. So if you've ever had a patient, I don't know if you've ever had a patient with a triglyceride level of 400 or 600 or 900, usually the LDL comes up blank, could not calculate. Triglycerides too high. So the fasting really helps with getting an accurate triglyceride level. Now, for most patients, does the triglyceride level make a difference in terms of their management? I would say for most patients, it doesn't. There's no direct correlation with triglycerides and cardiovascular events. So our entire goal for managing triglycerides is to reduce the risk of pancreatitis. And there's one study ever to show a reduction in risk with triglycerides, and that was the REDUCE-IT trial. And those patients had prior events or interventions, and they saw that a triglyceride level above 150 was associated with a significant amount of residual risk. And so if you reduce the triglycerides, you would reduce that risk by 20 something percent or so. So what I would say is one thing that you can do, the most important number on the lipid panel is going to be the LDL. And you can order a direct LDL count, which is not affected by fasting. And they can do that in the morning despite having had a meal. The other thing that we use is an apolipoprotein B, which is arguably a better determinant of future risk than LDL. And apolipoprotein B is present on all of the cholesterol particles that contribute to disease. So all the atherogenic cholesterol particles. It's on LDL, it's on lipoprotein A, it's on IDL and VLDL. And the ApoB number is also not affected by fasting. So in those situations, I think rather than having someone check their labs twice, you can use direct LDL, ApoB, and get a good sense of their cholesterol profile that way. As long as they're not someone with a history of severely elevated triglycerides where you really want to know that triglyceride number.
Awesome. Well, thank you for that clarification. I'll do my best. So now let's talk about medications that you commonly prescribe for people with cardiovascular disease, namely beta blockers.
Yes.
And I actually, when we look online, if you look at what are the medications that commonly cause sexual side effects, beta blockers show up, at the top of that list. And so I kind of naively assumed that every beta blocker had sexual side effects. And then I had a patient recently say, no, I'm on this one. And I read online that it actually might improve my sexual function. So I went right to you and I asked you, and you said, actually, that seems to be the case as well. Can you please describe how you describe the sexual side effect profiles with these different beta blockers?
Yeah. So as a drug class, beta blockers have impacts on erections. There's a higher ED incidence with beta blockers, but not all beta blockers are made the same. So we have about 8 or 9 beta blockers on the market. The older beta blockers are more likely to cause ED than some of the newer ones. So the older ones being atenolol and metoprolol. Metoprolol being probably the most commonly used beta blocker that I see in practice, and therefore the one that oftentimes I'm stopping when someone reports to me that they are struggling with erectile dysfunction. Oftentimes in men, if I'm going to use a beta blocker and I'm the one initiating the beta blocker, I stay away from those. And I tell them, I say, hey, I want to use this class of medication and I think we should, but these are more likely to cause ED. And so I'm going to try this one. And this one being nebivolol. So nebivolol is a nitric oxide mediated vasodilator, which some studies have shown may actually improve erectile function rather than cause ED. And so if a patient is able to tolerate it, nebivolol would be my preferred choice. The next choice, if they're unable to tolerate it for whatever reason.
Really quick, I want to go back. If you say if they're unable to tolerate it, what might they not be able to tolerate?
Yeah. So whenever you're using a medication that works via nitric oxide vasodilatation, some people may experience flushing, they may experience headaches, they sometimes may experience a little bit of orthostasis or dizziness. And I've had patients even on the lowest dose, nebivolol 2.5 milligrams daily is the lowest dose. Even with that dose, they say, hey, I took that medication and I felt, flushed, I felt dizzy, I really couldn't tolerate it. So that's the main thing. I don't see, obviously with any beta blocker, one thing that you're always going to be watching for is the heart rate. So they all reduce heart rate. And so if someone's heart rate drops below a certain point, and it's different for each person, they may feel like they're dragging their feet all day. They feel fatigued. They feel just tired. Sometimes they tell you, hey, I've been sleeping all day since I started taking this medication. It's probably that their beta blocker is causing symptomatic bradycardia. So those are the main things that I look for. For nebivolol, it's mainly, the flushing, the dizziness, etc. If they don't have that, that's my preferred choice. And I tell them that they may even see some improvement in their erectile function with that beta blocker. As an alternative, I will use carvedilol, which also is less likely to cause erectile dysfunction. And the incidence of erectile dysfunction with carvedilol is less than 5%. So it's not zero, but it's pretty low. And so those are the two that I'll use. So nebivolol and carvedilol, I stop any other beta blocker that they're on and try to switch them to one of those if it's someone that I know suffers with ED.
So for a lot of these patients who may have already been taking PDE5 inhibitors like Viagra, Cialis, or let's say they're coming to see me and I start them on it, and let's say they are on nebivolol, should my dosing of these medications be different?
Yes, I think whenever we're dealing with those interactions, not necessarily with nebivolol, I don't see it, but for our patients who are taking nitrates, so isosorbide mononitrate or isosorbide dinitrate, this is something that we counsel them on. So we try to avoid overlap. So we try to avoid taking a nitrate for 24 hours after sildenafil or vardenafil and 48 hours after Cialis or tadalafil. And this really is to prevent hypotension. Now, I'll tell you that rarely do we see this in our patients in actual practice. And I let them know, hey, there's an interaction between these medications, whether it be nebivolol or it's Imdor, isosorbide, or they have sublingual nitro that sometimes they take if they feel chest discomfort. I tell them, hey, if you're on Viagra or you're on Cialis, be very careful about taking this medication or watch out for these symptoms. When you stand up, do you feel dizzy? Check your blood pressure 3 times a week at different times, especially if you feel like you're lightheaded or you feel faint in any way. Check your blood pressure and, we can manage. We can either de-escalate our therapy or we can speak with their urologist to de-escalate the therapy on that side. So dosing does matter. Reducing the dose helps, but at the same time, if you reduce the dose and it doesn't work, I don't know if it's worth taking the medication. I'll leave that question to you. I see patients on different doses and I assume that they're being up titrated to a dose that works for them. And oftentimes what I do is I either change my therapy. We oftentimes have many options if they're symptomatic, and that does the trick.
Now, are there other medications that you would regularly prescribe where you would have this sexual health concern? I know hydrochlorothiazide is another one that pops up.
So this is a very commonly used diuretic. It's a thiazide diuretic. The incidence of ED with hydrochlorothiazide is actually pretty high. So what I'll do is reevaluate the need for that diuretic or use an alternative diuretic like spironolactone or aldactone. There we also run into issues with men, so I may use eplerenone. So with spironolactone and aldactone, what we see is sometimes men will come back and they feel like, hey, ever since I started taking this medication, my pecs are a little softer, or I feel like my muscles I just feel like weaker, etc. And the spironolactone does affect their sex hormones, and so we will change them to eplerenone, which is less likely to cause that issue. And I have multiple men on eplerenone; they do fine. So with the thiazide, yes, I will try to avoid it if they are experiencing ED. Some other medications that some people think may contribute to ED are statins. Statins do not. In fact, we think that statins may improve the risk of erectile dysfunction or erectile function net when you look at the improvement in endothelial repair that statins can provide the patient. So I reassure them if they're on a statin and I say, this is unlikely to be the cause of your ED. For the other common medications for blood pressure, we see a lot of lisinopril, losartan, so the angiotensin receptor blockers and ACE inhibitors. Really, it's a case-by-case basis. They're not strong. They don't have a strong impact on erectile function, but it can happen. I would say they're probably neutral, and it's usually not the cause of their ED. So I don't find myself stopping those very often. And that goes with our newer medications, our SGLT2 inhibitors, our GLP-1s, which a lot of patients are on, Govi, Zepbound, et cetera, Ozempic. I think the impact on erections there, I haven't seen anything to suggest a negative impact. If anything, it may be beneficial in that they're losing weight and they have the positive endothelial effects of those medications. So the big ones are going to be beta blockers and thiazide diuretics. I switched to nebivolol or carvedilol, and the thiazides, I usually stop them. We can control their blood pressure without thiazide diuretics. We can use an alternative diuretic such as eplerenone to manage their blood pressure.
That's very helpful. So my last question is the following. How often do you think cardiologists are bringing up sexual health in their offices based on your interactions with your colleagues? And what would it take, if it's low, to get more of them to bring it up?
I would say it's very low. I don't think that a lot of cardiologists are bringing up sexual health. I think.
So why do you? Or what got you into that, starting to have those conversations?
Yeah, I think, it starts with having a patient-centric approach to care. So I probably do a lot of things that my colleagues don't do. I find people new primary care doctors. I send people to urologists. When you have a patient in front of you, that's just another person with, maybe they have a primary cardiac issue that you're dealing with. But one, the way that you get the buy-in and the way that you get the trust of the patient to follow your instructions with respect to their cardiac care is really building that relationship. Seeing them as a whole patient. I think that as we've discussed today, you can't just focus on the heart. There are other parts of the body that are intertwined, whether it's their genital health or their sexual health, whether it's their kidneys, the liver, their brain, etc. We talk a lot about stress and mental health in my office visits, and I try to help them with that. I think all of that overall impacts their cardiovascular health positively. So I think the reason I discuss it is really just seeing patients and sympathizing with patients and practicing compassionate care. So if I see a gentleman, usually the men who are struggling with erectile dysfunction or any kind of sexual health issue, that is the predominant issue that they want to discuss with a physician. Yes, they have stents and yes, they had surgery last year, but they can't get it up when they go home at night, and that bothers them big time. And so once you break down that barrier and you're able to discuss it, you find out that, hey, we maybe it's something that we're doing that's causing a significant amount of decrease in the quality of life of this patient. If I can improve that, then absolutely I will. And so it really just started with the patient, being patient first and, learning how to ask the right questions in the right way. I'll say that with the beta blockers, it happens a lot. And so I'll see patients after surgery or after a stent, and they're seeing me for the first time. They've been on metoprolol for 6 months. The moment I begin to ask them about how are things in the bedroom, they're like, oh my God, since my heart attack, I haven't been able to do this and that. And, I haven't been able to get it up. And, I try to help them as much as possible. And you guys have been very helpful to me in seeing the patients and helping them regain their sexual function. And so that's kind of where it came from.
I love that. Do you have time for one more question?
Yeah.
What's your message to urologists from a cardiologist? What if you had a megaphone? And right now, Dr. Dapo, I'm giving you a megaphone. What do you want us to know?
I think erectile dysfunction, we should really begin to think of erectile dysfunction as subclinical atherosclerosis until proven otherwise. And so for those patients, it really shouldn't just be erectile dysfunction that we're looking at, but we're looking at their cardiovascular risk. You may be the first person to see this patient and have the first opportunity to diagnose them with that subclinical atherosclerotic disease. I really think the patients and the cardiovascular community would love for urologists to view it in that way, to feel free ordering the lipid panel. I'm going to stress again, lipoprotein A for every single individual once in their lifetime. You mentioned advanced lipid panels. I think that's a great way to just catch it all and get a good evaluation. You'll get the lipoprotein A, you'll get the ApoB. And when erectile dysfunction occurs in a man under 55 years of age, I think it's really important for us to consider, doing a calcium score, consider getting a preventive cardiology consultation, because that may be someone who in the next 5 to 10 years is seeing us in the ER with a heart attack. Like I said earlier, patients present typically 2 to 3 years before their cardiovascular symptoms. They present with erectile symptoms. And so this would be my message for urologists. And I look forward to sharing patients with you guys and sharing information. And hopefully we get more data that sheds light on this issue and the intersection between cardiology and urology.
I love that. What a powerful message to leave us with. Dr. Dapo, thank you so much for joining us today on BackTable Urology. Stay tuned for the next episode, folks.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening and see you next week.